So, good morning, friends, seniors, and my colleagues. After such a wonderful talk, opening batsman Kapil sari batting કરી. હવે next is high risk hypertension. સાલું એક વસ્તુ નથી સમજાતી, બધી વસ્તુમાં લોઅર ધી બેટર. બીપી તો કે હવે 130/80, HbA1c તો 6.5, LDL તો પહેલાં 70, હવે 50, હવે હાઈ રિસ્ક, વેરી હાઈ રિસ્કમાં 30. પણ આલ્કોહોલના પેગ તો MBBS ભણી છે ત્યારથી 2ના 2 જ છે, એ કોઈ નથી ઘટાડતું. ગુડ. સો વાય હાઇપરટેન્શન ઇઝ સો ઇમ્પોર્ટન્ટ? શું કામ આપણે આટલું બધું હાઇપરટેન્શનને બીઇંગ કાર્ડિયોલોજિસ્ટ ઇન્ટરવેન્શન સિવાયના આજના જે ટોપિક્સ છે એમાં હાઇપરટેન્શન પ્લેઝ અ ક્રુશિયલ રોલ, બિકોઝ ઓવરઓલ ઇફ યુ સી ધી પ્રિવેલન્સ ઓફ હાઇપરટેન્શન વર્લ્ડ વાઇડ ઇઝ 25% અને ઇન્ડિયા બધી જ વસ્તુઓમાં હવે આગળ વધી રહ્યું છે. ઇન્ડિયા ઇઝ બિકમિંગ ડાયાબિટીક કેપિટલ, હાઇપરટેન્સિવ કેપિટલ, CAD કેપિટલ. તો આપણા માટે આ બહુ જરૂરી છે. વેરી ઇમ્પોર્ટન્ટ ટુ નો હાઇપરટેન્શન, ટુ ટ્રીટ હાઇપરટેન્શન. એક યુએસની સ્ટડી છે. Total hypertensive patients, out of them, 21% are unaware of the blood pressure. Of those who are aware of blood pressure, 10% are untreated. જેટલાને ખબર છે એમાંથી 10% are untreated. Of those who are treated, 24% are uncontrolled. So total માંથી 55% of the total hypertensive patients in US are not at goal. ઇન્ડિયાની તો વાત આપણે કરતા જ નથી, યુએસમાં પણ 55% આર નોટ એટ ગોલ, વિચ મીન્સ this is a significant chunk of patient who will then progress to either renal, cardiac or CNS adverse effects. So this is a simple slide. Kapile already હમણાં ગાઈડલાઇનમાં કીધું, targets are getting lower and lower. Just a brief, 140, 90 or more on multiple recordings without any risk factors, you need to start medicine. If there are other associated risk factors like already cardiovascular disease છે, or patient is known case of CKD, diabetes or at high risk of CVD in future, 10-year risk more than 7.5, to initiate blood pressure medicines when the BP is more than 130/80. So lower the better comes here also. So what is this high risk hypertension? Routine hypertension તો આપણને ખબર છે, પણ high risk hypertension, who all qualifies for high risk hypertension? So any blood pressure more than 180 systolic, more than 110 diastolic, those with diabetes and hypertension, those with metabolic syndrome, those with subclinical organ damage, proteinuria or LVH on ECG and echo, those with established CKD, associated CAD, CVA or PVD, and those with secondary hypertension. These are the subset of patients who qualify for high risk hypertension. They need more attention and more stringent blood pressure control and to prevent future organ damage. So brief માં કહીએ ને તો CKM કે છે. CKM is kidney, cardiovascular and metabolic syndrome. આમાં બધું આવી ગયું. High risk માં those with CAD, CVA, those with CKD or proteinuria, early end-stage renal disease, those with metabolic syndrome like diabetes. So our subset of patients are those patients who are high risk, who need to be treated more cautiously. Now directly આપણે કેસ તરફ જઈએ. આપણે 3 કેસ હું પ્રેઝન્ટ કરીશ. They are those cases which we see day in and day out. So he is a 42-year gentleman. He works as a medical representative. અને એ લોકોનું કામ સિરિયસલી બહુ જ સ્ટ્રેસફુલ હોય છે. ફ્રીક્વન્ટ મીલ્સ ફ્રોમ રેસ્ટોરન્ટ, રોડ સાઇડ સ્ટોલ્સથી ખાય છે. He is a known case of diabetes since 6 to 7 years, hypertensive since 10 years. Still, if despite of he being on medicines, his blood pressure is uncontrolled, 148/94, his sugar is uncontrolled, he is having proteinuria on urine examination and is having LDL of 127. So no cardiovascular symptoms, no normal ECG, કાંઈ એને symptoms નથી. એ રૂટીન એનું કામ કરે છે, but his job is stressful. And this stressમાં we commonly see in OPD કે patients પોતાની BP, diabetesની medicines irregularly લેતા હોય તો follow-up ન લેતા હોય, they are not controlled. So આ કઈ રીતે આપણને નડે on a long run? Just to brief, 36% of Indians suffer from hypertension, 11% from diabetes, and around 15% are pre-diabetic. So as I said earlier, આપણે કેપિટલ બનતા જઈએ છીએ બધાયમાં, ટ્રમ્પ આપણી એટલે તો પતા ઠોકે છે. So up to 50% of hypertensive patients in India are diagnosed with type 2 DM. એટલે hypertension treat કરવું એટલું જરૂરી છે જેટલું એની સાથે we need to keep a watch on diabetes and cholesterol. So why it is important? Again, 50% of hypertensive patients in future will have diabetes, and both of them together are partners in crime for organ damage. Which all organs? Kidney ma, it starts with albuminuria leading then to CKD and stage renal disease. Heart ma LVH thi start thai, then it goes to heart failure and CAD, stroke and cognitive dysfunction, and retinopathy in the eyes. So આ રીતે both of them lead to target organ damage. So આપણો જે કેસ છે પેશન્ટ એને શું પ્રોબ્લેમ્સ? એઝ આઈ ટોલ્ડ, અનકન્ટ્રોલ ડાયાબિટીસ, અનકન્ટ્રોલ બીપી એન્ડ આલ્બેન્યુરિયા, ત્રણેય વસ્તુમાં ઇઝ નોટ બોધરિંગ હિમસેલ્ફ, એન્ડ વી નીડ ટુ એજ્યુકેટ ધેમ, વી નીડ ટુ ટ્રીટ ધેમ. મોસ્ટ ઇમ્પોર્ટન્ટ ઇઝ it is not only BP control. એવું નથી કે ટાર્ગેટ એક ફિગર it is like 130/80 ની નીચે આવી ગયો એટલે we are assured. No. Initial focus was lower the BP to the target, but now the focus is shifting to protect the target organs also. Target organs માં ખાલી blood pressure આવતું નથી, we need to treat associated abnormalities also. Organ protection is the key therapeutic goal, not just BP lowering. So what are the changes we need to do આમાં? Most importantly, lifestyle changes. Stress બધાની લાઈફમાં છે અને it is causing increased blood pressure, increase in stress leads to all these things. We need to have significant lifestyle changes, yoga, diet control and weight loss. Already Kapil has mentioned primary, આ બધું બહુ important છે. We in India, there was a study જેમાં 40% of Indians every week at least twice a day sweets ખાય છે. So we are having increased refined flour consumptions, dairy and dairy products, increased salt intakes. આ બધું જે wafers ને બધું packaged foods છે, they are highly salty, and increased salt intake, excessive sugar intake. તો આ બધું we need to curb all this. So all the guidelines are on a single page for the first line antihypertensives. There are two things, first line, second line. The first line માં બધી guideline એમ જ કહે છે કે ACD, ACE inhibitors or ARB, CCBs and diuretics. They are the first line treatment. And હવે ઇન્ડિયામાં તો આપણે વર્ષોથી જોઈએ છીએ multiple pill combinations. But the all guidelines now endorse કે by single pill combination helps better control and patient adherence. So ACE, CCB and diuretics are the first line treatment. Beta blockers to be added only as and when required. So what all changes needs to be done in this patient? Lifestyle modification કઈ રીતે? તો daily 30 minutes walking, at least moderate intensity walking. ખાલી આપણે બગીચામાં આંટો મારવા જઈએ એ રીતે નહીં, પરસેવો પડવો જોઈએ. 30 minutes a day, moderate intensity walking, at least 5 days a week, with salt restriction, salt less than 5 gram per day, or Na sodium intake 2.4 gram per day, stress management and meditation. Second most important is blood pressure control. It should be less than 130/80. Multiple recordings less than 130/80. As this patient is having albuminuria, the next best medicine to be added would be telmisartan. It will help in BP reduction. Second important thing, young hypertensives are high renin hypertension. There are two categories of hypertension: high renin hypertension, low renin hypertension. So one size fits for all એવું નથી. Elderly patients, if they come with a blood pressure of 180/90, the drug of choice is not telmisartan. They are low renin hypertension. The drug of choice is either CCB or thiazide diuretics. એને તમે ટેલ્મિસાર્ટન બીટા બ્લોકર કોમ્બિનેશન આપો, એનું બીપી 10 મિલીમીટરથી વધારે નહીં ઘટે. યુ ગીવ ધેમ એમ્લોડિપિન ઓર સિલ્નિડિપિન કોમ્બિનેશન વિથ અ ડાયરેટિક, their blood pressure will be under control. On the other way, young patients, because of stress and because of multiple factors, they are high renin hypertension. The drug of choice is ACE inhibitors or ARBs. Third important thing is glycemia control. HbA1c should be less than 7, between 6.5 to 7, and he can be initiated on a triple drug combination of DAPA, CETA, metformin combination. Next important thing is LDL. He is already having hypertension, diabetes. He is 42. His LDL is 127. Over a long run, this is definitely going to affect him. His LDL needs to be less than 100, and newer guidelines say less than 70. He needs to be started on statin therapy. And most importantly, home BP monitoring should be encouraged. Hospital e na ho to kai nahi, at least you keep a watch on your BP at home. So આ બહુ કોમન છે. ઓપીડીમાં પેશન્ટ બેઠા હોય, સાહેબ 2 કલાકથી બેઠો તો એટલે બીપી વધી ગયો હશે. That's why we need કે ambulatory and home BP monitoring should be encouraged. So next case, again a young patient, 35 male, software engineer, non-smoker, occasional alcoholic, with a family history of hypertension, normal body weight, a BMI of 25, presented with history of headache, palpitation and uncontrolled BP despite of triple therapy. 3 drug already liye છે, still he is symptomatic and he is having uncontrolled BP. There is no other history of diabetes or drug abuse or OSA. Blood pressure was 166 by 104, regular pulse rate, grade 1 hypertensive retinopathy with normal cardiac examination. His basic lab investigations were normal except for a potassium of 3.1. ECG and echo showed LVH. So where does this point to? Young patient che? Yes, exactly. This is a case of secondary hypertension. We need to investigate this patient for secondary hypertension before labeling him as primary hypertension. Generally, આપણે ભણતા ત્યારે એવું કહેવાતું કે 30 થી 50 ની વચ્ચે બ્લડ પ્રેશર આવે તો એ જનરલી પ્રાઇમરી હોય. પણ this triple drug therapy થી uncontrolled young patient, he needs to be investigated for secondary hypertension. So what are the causes of secondary hypertension? Most important causes are 1, OSA, 2, primary hyperaldosteronism, and 3, renal parenchymal disease. These are the 3 most common cause of secondary hypertension. Others being renovascular hypertension, which is again more common in elderlies with renal stenosis or young female with fibromuscular dysplasia, pheochromocytoma, Cushing's, all endocrines, thyroid, hyperparathyroidism, and rare cases could be coarctation of aorta. So what is primary hyperaldosteronism? It is nothing but increased inappropriately high aldosterone secretion, either because of adrenal hyperplasia or adrenal adenoma. So this, coming to the case, he was investigated for secondary causes. His ARR, aldosterone renin ratio, was more than 100, which is highly suggestive of primary aldosteronism. Importantly, these are treatable causes of hypertension. CT abdomen showed a left adrenal adenoma. He was started on spironolactone 25 milligram with improved his blood pressure, was operated. After 3 months, he was off antihypertensives, potassium normalized, and at 3 months and at follow-up 1 year, LVH started regressing. So importantly, young hypertension resistant to multiple drugs associated with hypokalemia should prompt evaluation for secondary causes. Primary aldosteronism is common. Early identification is crucial as surgical cure is possible, and it highlights that young patient ne primary hypertension label karta pehla we should evaluate secondary causes. Moving to the third case, એક બહુ કોમન સિનેરિયો છે ઇન્ડિયા યંગ પેશન્ટનું અત્યારે હબ છે. મેક્સિમમ નંબર ઓફ યંગસ્ટર્સ આર ઇન્ડિયા, વિચ ઇઝ વાય વી આર મોર પ્રોડક્ટિવ ઓલ્સો, બટ એની સામે એના ડ્રોબેક્સ પણ છે. 45 years સ્કૂલ ટીચર, obese, long standing hypertension since 10 years, occasional pedal edema without any other history. So ઓપીડીમાં ઘણા પેશન્ટ હવે પોસ્ટ કોવિડ અવેરનેસ વી ઓલ્સો નો વધી ગઈ છે. લિપિડનો રિપોર્ટ લઈને આવે, બ્લડ પ્રેશર સાથે આવે કે સાહેબ કંટ્રોલમાં નથી આવતું. સો વી નીડ ટુ ડેફિનેટલી ઇવેલ્યુએટ all of them. So blood pressure was uncontrolled despite telmisartan, which was increased to 80 milligram. No other history except for family history of hypertension and CKD. This is also important. She had minimal pedal edema with a BP of 150 to 90 and other systems were normal. So routine blood investigation showed a creatinine of 1.8 elevated. She is now into early CKD with a increased albumin excretion, normal HbA1c, a LDL of 160 and LVH on ECG and echo. So she is already having target organ damage, kidney, heart, BEMA target organ damage has started. So diagnosis, we all know CKD early with uncontrolled hypertension and target organ damage. So what makes Indians more prone to early kidney damage? It is a mixture of all this: uncontrolled hypertension, diabetes, salt sensitivity, obesity, dietary practices, packaged food બહુ વધારે ખાવાની ટેવ, overuse of NSAIDs, over the counter medicines બહુ commonly મળી જાય છે. એટલે લોકોને કાંઈ પણ નાની મોટી સિમ્ટમ્સ હોય અથવા જીપી પાસે જઈએ તો આઈ વુડ એડવાઇઝ કે એકવાર ક્રિએટિનિન કરે બિફોર ગિવિંગ ધેમ NSAIDs ફોર અ લોંગર પીરિયડ. સ્મોકિંગ એન્ડ આલ્કોહોલિઝમ and some environmental reasons. So same first patient જેવું જ છે. First patient હજી આપણું જે હતું એ CKD માં એન્ટર નહોતું થયું. Now this patient has already entered into CKD with target organ damage. So what all things we need to take care of? બધું જ આમાં તો deranged છે. We need to achieve BP, we need to slow the progression of CKD. Already CKD માં patient has entered. Maintain electrolyte balance and we need to think of long-term CV risk. So when to begin renoprotective therapy in hypertensive patient? કેટલા પેશન્ટ ઓપીડીમાં આવે? બધું ઓકે છે, આપણે એમને મેડિસિન્સ લખીને જવા દઈએ? નો. Earlier the better, right from the start. Urine microalbuminuria is one of the first tests કે જેમાંથી ખબર પડે કે this patient is now going towards early phase of CKD or end organ damage. Second is retinopathy. Third is already we know ECG માં LVH. So all these are minor points which tell us કે આ patient હવે deteriorate થશે. So this study showed that early intervention significantly delayed the progression of CKD. કાંઈ નથી કરતા તો at 7 years he will end up into renal failure. But the earlier we intervene, the later he will fall into renal dysfunction. So what all things we need to take care? શું એડ કરશું આમાં? એક પછી એક આપણે એડ કરતા જઈએ મેડિસિન. ફર્સ્ટ ઇમ્પોર્ટન્ટ ઇઝ she needs tight BP control, target less than 130/80. So what all medicines? First line હજી આપણી પાસે બાકી છે. She is already on telmisartan 40. Can anybody tell what medicine will add? Yes. Next would be we start with adding CCBs. And amongst the CCB, this was an Indian study which showed that cilnidipine reduces blood pressure, reduces heart rate, reduces proteinuria with no, significant delay in progression to CKD. Next, આનાથી control નહીં થાય તો what all things we can add? Diuretics, true. So if the GFR is less than 30 or more than 30, if it is more than 30, we can add thiazide group of diuretics. If the GFR is less than 30, we need to start with loop diuretics. What else? એનાથી control થાતું. So yes, diuretics, CCBs થઈ ગયા, beta blockers. Young patient, high sympathetic tone, stress, definitely beta blockers can be helpful. Then next would be mineralocorticoid receptor antagonist. Vasodilators. Hydralazine and minoxidil, and nowadays even isolazine, which is a combination of hydralazine with isosorbate dinitrate. It helps in significant blood pressure control. Alpha blockers, prazosin, and central sympatholytics like clonidine and moxonidine. So this is the basket of medicines which we have. Medical management પૂરું થયા પછી if the still BP is not controlled, then as Kapil told, we can go for sympathetic denervation, renal sympathetic denervation. So next, BP તો control થઈ ગયું, હવે શું? Renoprotective add-on therapy. These are very important other medicines. So finrenone, It's a novel, selective, non-steroidal mineralocortical receptor antagonist with anti-inflammatory and anti-fibrotic properties. It is helpful in patients with non-diabetic CKD, diabetic CKD, heart failure and pediatric CKD. So this is a newer agent which definitely delays the progression to end-stage renal disease. Next is add-on dapagliflozin. This was a DAPA CKD trial which showed that dapagliflozin significantly reduces the risk of kidney failure, death and hospitalization and on-call mortality in patients with CKD with or without diabetes. So control of blood pressure, addition of finrenon, addition of DAPA. Most important again, lifestyle changes. Physical activity, yoga, meditation, weight reduction, salt restriction, and most important again, avoid nephrotoxic agents. Because a single course of NSAIDs can land her up from early CKD to end-stage renal disease. Again, as I told already, dyslipidemia management is very important. Target LDL less than 70, amnu LDL hatu 160. We need to start her on statins. And I would emphasize statins સાથે ezetimibe because ezetimibe is a cholesterol receptor, a cholesterol absorbent inhibitor. આપણું food fats માં high હોય છે. So 10 milligram statin with 10 milligram ezetimibe will give the result which we require, target LDL less than 70. So we need to treat patient as a whole. ખાલી targets નહીં, BP 130/80 નહીં. It has to be prevention of end organ damage and prevention of progression to end stage renal disease, along with management of diabetes, along with management of dyslipidemia. This whole basket is to be there. It is not only blood pressure target. Thank you.